Hello my dear colleagues, welcome to this your channel Clinical Consultant. In the previous video I talked about the brain abscess. I will leave a link in the description so that you can see it in case you have not seen it. Today we will talk about spinal epidural abscess as promised in the previous video, a serious topic that has serious consequences if it is not treated in time. Let's continue. Definition. An epidural spinal abscess, ESA, is a spurt of infection that affects the epidural space. As we see in the image, the epidural space is located within the vertebral canal between the dura mater and the yellow ligament. In the blue dates we have the anterior epidural space, and the red date the posterior epidural space. Epidemiology. Incidence is 2 to 25/100,000 hospitalized patients per year. It may have been increasing in the last decade. Average age of approximately 50 years, 35 in injecting drug addicts. Maximum incidence in the 7th and 8th decade of life. Signs and symptoms. Although they can be nonspecific in most patients we can find fever, back pain, which may be mild at the beginning, but can gradually be severe and immobilizing. As the disease progresses, radicular pain, motor weakness, sensory changes, bladder and bowel dysfunction, and paralysis may appear. Symptoms at first may be limited to fever and spinal tenderness. The progression to neurological deficit can occur in a few hours, weeks or months, and can become irreversible if not intervened properly. Etiology. Bacteria are the main cause of this pathology. Cases of tuberculosis may occur. They can also be caused by fungi and parasites. The most frequently responsible microorganism is Staphylococcus aureus. Most posterior cells are believed to originate from a distant focus, example, skin and soft tissue infections, whereas anterior cells are associated with vertebral disorders or schiomyelitis. In 1/3 of the cases the foci are not found. Associated predisposing diseases include compromised immune system, such as that affecting patients with diabetes mellitus, alcoholism, cancer, AIDS and chronic kidney failure, or having undergone epidural anesthetics, surgery or spinal trauma, parenteral drug use. Predisposing diseases are not seen in 20% of patients. Spinal cord injury can be caused by direct compression, vascular compromise, bacterial toxins, or inflammation. Differential diagnosis. Herniated disc, vertebral schiomyelitis and ascites, metastatic tumors, meningitis. Lab tests. Leukocytes may be normal or elevated. The VCG is usually elevated, above 30 mm/H. Blood cultures are positive in approximately 60% of patients with ESA. CSF cultures are positive in 19%, although lumbar puncture is not necessary and could even be contraindicated. Once images are available, a CT-guided aspiration or open biopsy should be performed to identify the causative organism. The culture of the abscess content is positive in 90%. Imaging diagnosis. The technique of choice is MRI with gadolinium. CT with contrast can show the abscess. CT with myelography is more sensitive in cases of spinal cord compression. Treatment. We have 3 types of treatment: the non-pharmacological, the acute treatment, and the chronic treatment. The non-pharmacological treatment, surgical decompression, is the mainstay of treatment. The decompression, carried out in the first 24 hours, has been shown to improve the prognosis. Non-surgical treatment is effective in some patients, although the failure rate is excessive. Such a strategy should not be considered in most patients. The acute treatment. In addition to surgery, antibiotics should be administered against the most likely microorganism. If the organism is unknown, a broad spectrum of pathogens should be covered, such as Staphylococcus, Streptococcus, and gram-negative odds. The regimen can be adjusted according to the results of the culture. Treatment should continue for at least 4 to 6 weeks. In the chronic treatment, neurological deficits may persist despite aggressive treatment. Forecast and referral. Forecast. Up to 25% patients can suffer irreversible paralysis and dead. Derivations. All cases should be referred to a neurosurgeon and an infectious disease specialist in some countries. Forecast and referral. Forecast. Up to 25% patients can suffer irreversible paralysis and dead. Derivations. All cases should be referred to a neurosurgeon and an infectious disease specialist in some countries.